Welcome to the third in a series of presentations on spinal radiography. The intent of this presentation is to provide a description and examples of intervertebral disc disease in the dog and cat. By the end, you should be able to identify and describe the radiographic findings of disc degeneration as well as suggestive signs of intervertebral disc herniation. Clinical signs of intervertebral disc disease result from protrusion or herniation of the intact intervertebral disc or of the nuclear disc material into the vertebral canal, causing compression on the spinal cord or the nerve roots. Chondrodystrophic breeds are the most commonly affected, and I've listed several of the most likely breeds. But remember that intervertebral disc disease can occur in any breed, as we've already seen in the Doberman Pinscher or other large breeds as part of cervical spondylomyelopathy, and we'll talk a little bit more about this. Specifically, intervertebral disc protrusion or herniation can occur in any portion of the spine and is quite common in dogs, less so but still possible in cats. There are several common sites in the cervical and caudal thoracic spine, but intervertebral disc herniation is at all sites potentially, with the exception of C1-2 because there is no intervertebral disc at that site. Type 1 protrusion follows chondroid degeneration of the nucleus pulposus with eventual expulsion of dehydrated material into the vertebral canal, oftentimes mineralized material. And these are very common in the chondrodystrophic breeds and usually produce very acute clinical signs. Type 2 protrusion follows fibroid degeneration and metaplasia of the nucleus pulposus with eventual stretching, hypertrophy, or partial rupture of the annulus fibrosus. And oftentimes mineralization is not a part of this process. These are most often the non-chondrodystrophic breeds. And type 2 protrusion usually presents with chronic and progressive signs. Other variations on type 1 and type 2 exist, but a complete discussion is beyond the scope of this presentation. Intervertebral disc disease is the degeneration of the disc and not necessarily the herniation of the disc. And if we see anything on a radiograph, the finding is of mineral opacity in the intervertebral disc space. This is going to be most easily identified on the lateral view, and this is a lateral view of a chondrodystrophic breed dog who has numerous sites of intervertebral discs which are mineralized. So the normal intervertebral disc should be soft tissue opacity, and so it will look as a lucency of the intervertebral disc space between the two vertebral bodies. But when we start to see degeneration which mineralizes, we'll start to see that there is varying mineral opacity within or affecting that nucleus pulposus. You can see in this patient there are some small sites of mineralization and then some larger sites of mineralization and then some that are just partially mineralized. So this patient has numerous sites of variable mineralization of the intervertebral discs. Also, be careful that you're not mistaking overlapping ribs and rib heads with mineralization or even the transverse processes. We don't want to mistake the mineral opacity of the transverse process as intervertebral disc mineralization. I need you to remember that seeing mineralized disc material in situ, or where it's supposed to be within the intervertebral disc space, does not cause clinical signs. It's only when a portion or all of that mineralized disc protrudes or herniates into the vertebral canal that it actually causes the clinical signs. Here's an example of a cat that has several sites of in situ mineralized intervertebral discs indicated by the arrows. So again, normal sites, we should have a lucent soft tissue opacity between the vertebral bodies in that intervertebral disc space, and in this cat we have a small site and a little bit larger site and then even a little bit larger site of mineralization in situ where it belongs. When a patient presents with actual clinical signs, then we're going to evaluate our radiographs critically for findings that would suggest that the intervertebral disc has actually protruded or herniated. Keep in mind that sensitivity and specificity of radiology are poor when compared to CT and MRI. However, critical evaluation can find signs that will suggest that intervertebral disc herniation is the cause, and also can be important in ruling out other conditions such as a fracture, luxation, or aggressive bone lesions. The image on the bottom is actually of a normal patient, just to remind you where we're going to be looking for these radiographic findings. So one of the first signs that I look for is that the normal intervertebral disc space, which is outlined by the yellow shading here, will not be the normal space. So again, we'll compare each one to the one in front and the one behind. And if that space is narrowed or wedged compared to the others, that can suggest that the disc is no longer present to keep the intervertebral disc space in its normal spacing. The intervertebral foramen is another area that we're going to assess. And so the intervertebral foramen is kind of that little horse head or Snoopy head, that space between the two vertebrae where the nerves exit. And we will want to compare those intervertebral foramen, so again outlined in the orange here, to make sure that their shape and size has stayed the same. So when there is disc herniation, that intervertebral foramen can be smaller than the adjacent ones. Also, especially for type 1 mineralized discs that herniate, we're going to assess for mineral opacity within the vertebral canal or at the level of that intervertebral foramen. So we might see more opacity than we'd expect. And then finally, I think this is one of the more challenging findings. You can look at the spacing between the articular processes. We normally have this little crescent lucency, and that's outlined by blue here. If everything is coming closer together because the disc has herniated, then that articular process joint space may also be small. So let's look at some examples. This first dog, I've got lateral and ventrodorsal views of a dog that has radiographic signs of herniation at T11 and 12. So in the lateral view, we're centered at the thoracolumbar junction. Here are the last set of ribs, so this is T13. When I look at this patient, and again, you can use that 3-pass method, dorsal compartment, middle compartment, ventral compartment. When I look at the intervertebral disc space here at T11, 12, it is wedged and narrowed compared to the space behind it at T12, 13. Now, we're not going to compare it to the spacing of T10, 11, because remember, that's our anticlinal intervertebral disc space, which is always narrow. This one also has mineralization in situ, so that's going to kind of confound our looking at spacing. So going back to T11, 12, besides that disc space being narrowed and wedged, I'm looking at the intervertebral foramen here, and it is not as lucent as the one in front and the one behind, so it has increased mineral opacity, and that also makes it look smaller. So we have a smaller intervertebral foramen. Now, this patient also has other sites of varying mineralization of intervertebral disc in situ. So radiographic findings are at T11, 12 suggestive of intervertebral disc herniation. On the ventrodorsal view, it's a little bit more challenging, and we also have to be a little careful. Although the disc space at T11, 12 here looks narrowed, sometimes the other disc spaces, like the one at T12, 13, looks narrowed, and we can see when we look at our lateral view that that's not actually a true finding. So I always want to look for my spacing on my lateral view. Here's another example of a patient that has radiographic signs of herniation at T12 and 13. One thing I'm going to notice right away on this lateral view is we are a little bit rotated. So we're going to have to be a little bit careful when we assess because of that rotation. So remember, we want to be pretty straight and try to critically position our patients. Also, the site we're going to look at is more at the edge of our image. And so ideally, we would be more centered at the site of problem. But when I look at this patient using my 3-pass method, I see that the intervertebral disc space at T12-13 is actually narrowed compared to the intervertebral disc space behind it at T13L1. When I look at the intervertebral foramina at these 3 sites here, I see that within the plane of that intervertebral foramen at T12-13 is also this mineral opacity in the canal. And then this patient has a little bit of a narrowed articular joint space at T12-13 if I compare it to the lucent spacing ahead and the lucent spacing behind. So narrowed intervertebral disc space, increased mineral opacity in the spinal canal in the vertebral canal at the intervertebral foramen, and then mild narrowing of that articular joint space. There is also a mineralized intervertebral disc in situ at T11-12, and then remember the narrowing at T10-11 is normal narrowing. Now as we go caudally here too, I see some other mineralized discs within the lumbar and lumbosacral spine. And then be careful that since we're kind of rotated and crooked, some of the mineral opacity you see are actually the caudal end plates on the other side. This is the same dog in the previous slide where we have images of the MRI just to confirm and ensure that our radiographic findings are the cause of the clinical signs. And so on the MRI, this is the site that we saw in the radiographs, T12-13, where again the cord is this kind of medium gray, and within the vertebral canal, this is that really black mineral intensity that we saw on the radiograph that is completely compressing that cord. We can also see it on a transverse image where this is all of that mineralized disc and there's very little cord. In comparison to a normal site where we have the medium gray cord with some brighter white, which is our fat and our subarachnoid space, where there's no cord compression. Here's a lateral view of a dog that has radiographic signs of intervertebral disc herniation at L2 and L3. So on this patient, when we do our 3-pass method, what I really notice is when I'm looking at my middle compartment that there is this large oval mineral opaque structure that is in the plane of the vertebral canal, kind of encroaching on and making that intervertebral foramen look small at the level of L2-3. I think the intervertebral disc space is probably mildly narrow compared to the one in front of it. And then if we look at the intervertebral disc space caudal to it at L3-4, there's actually some mineralized intervertebral disc material in situ. So again, radiographic signs consistent with disc herniation at L2-3. Here's an example of a cat that also has clinical signs related to intervertebral disc herniation. On the radiographs of this cat, I can see the findings on the lateral view best, and I see a few different abnormalities, but the first thing that I noticed when I was evaluating is that the intervertebral disc spaces at L4-5 and L5-6 are narrowed when I compare it to the spaces around. Also, I see, especially at L4-5, there's quite a bit of mineral opacity within the vertebral canal at the level of the intervertebral foramen that's making that foramen quite small. There is a small amount of mineral opacity within the ventral aspect of the vertebral canal at the level of L5-6 intervertebral foramen. And then this patient also has mineralization of the intervertebral disc at L3-4 in situ. But radiographically, I would be most concerned about L4-5 because of the large amount of mineralized intervertebral disc material. However, I wouldn't be able to know that there wasn't also a problem at L5-6. So that's where follow-up with CT or MRI will provide us additional information for surgical planning. This is an example of a dog that has radiographic signs of intervertebral disc herniation at C4-5. I do think that it can be a little bit more challenging when you're evaluating the cervical spine because the articular processes actually are a little bit more ventral and slanted so that they actually get superimposed over the vertebral canal. So be a little careful when you evaluate them there. However, when I look at this patient's lateral view, I see that the intervertebral disc space here at C4-5 is narrowed and slightly wedged when I compare it to C3-4 and C5-6, so quite a bit narrowed. The patient is pretty well positioned through this area, so I think that's a real finding. And then when I critically evaluate the vertebral canal, when I'm looking at that middle compartment, there's actually this mineral opacity that is in the plane of that intervertebral foramen, in addition to the articular process superimposition that I see. So if I compare the kind of canal here and here, ahead and behind it, I do see this additional mineral opacity. So these are radiographic findings that would be consistent with herniation at C4-5. Be sure to look at the textbook chapter and pages that I've listed here so that you can have some additional explanation, but also see some additional examples of intervertebral disc disease and herniation.